Hello, and welcome to the Clinical Care Options in Pro-CE Infectious Disease podcast. I'm your host, Jacqueline Meredith. This episode, Dr. Ann Justo, Infectious Diseases Clinical Pharmacist at Dartmouth Hitchcock Medical Center in Lebanon, New Hampshire, shares her approach to treating infections caused by Carbapenem-Resistant Enterobacterales, or CRE. For more information about Dr. Justo, and for a link to the full online educational program, including the accompanying ClinicalThought commentary and downloadable infographic, please visit the link in the show notes. Now let's get started and hear what she has to say about this topic.
First, let's set the stage with a patient case. You receive a blood culture update for a male patient admitted to the hospital with fever, night sweats, and decreased urination. His past medical history is significant for paraplegia, requiring a chronic suprapubic catheter, and the patient also has a history of recurrent urinary tract infections. His most recent UTI was 3 months ago, and he was treated with levofloxacin. The blood culture this admission comes back flagged for Carbapenem-Resistant Enterobacterales. His culture is specifically growing Klebsiella pneumoniae, and the specific carbapenem resistance mechanism is identified as New Delhi metallobeta-lactamase, or NDM, and this was done via genotypic testing. Full susceptibility testing results across a bevy of antibiotic agents are still pending. With this case, unfortunately, the frequency of this type of story is increasing throughout the United States. In this commentary, I'll review the changing epidemiology of CRE, contributing mechanisms of resistance, and a reasonable clinical approach to a patient case such as this. So first, let's talk a little bit about the epidemiology of CRE resistance. Right now, a minority, only about 2.7%, of all the Enterobacterales isolates tested in 2020 in the United States were deemed to be carbapenem resistant. But even with this relatively small proportion, CRE remain an urgent threat in healthcare, accounting for an estimated 12,700 cases and 1,100 deaths in the year of 2020. That annual CRE infection and death rate remained relatively stable between 2019 to 2020, but importantly, we noticed an interesting trend. Hospital onset cases actually increased by 35%, again between 2019 and 2020. CDC is hypothesizing this probably has to do with the COVID-19 pandemic, but we're going to have to watch these epidemiological data closely to see if this trend will continue. Now, there are several mechanisms that can be responsible for carbapenem resistance among Enterobacterales. These can be broadly divided into carbapenemase-producing and non-carbapenemase-producing mechanisms. First, let's talk about carbapenemases. These specifically refer to enzymes that hydrolyze the carbapenem antibiotic and render it inactive. Carbapenemase-producing CRE, better known as CpCRE, represents 35 to 59% of all CRE isolates in the United States, with the most common being Klebsiella pneumoniae carbapenemase, or KPC, followed by the broader family of metallobeta-lactamases, or MBLs, and within that family, particularly NDM, that was found in our patient case, looms fairly large. The prevalence of CpCRE varies by region. However, since 2020, the United States has seen a general increase in the specific subset of MBL-producing Enterobacterales. In a surveillance study evaluating more than 27,000 Enterobacterales isolates from 74 U.S. medical centers, the proportion of CRE isolates that produce MBLs increased dramatically from 3.8% in 2019 to 20.4% in 2021. The majority of these MBLs actually were in fact NDM. So this is an important trend that you as clinicians should be aware of and should be monitoring for. Now, switching gears to the non-carbapenemase producing mechanisms of carbapenem resistance, they represent a wide variety of changes that are possible in the bacteria. Often, multiple changes can even be occurring simultaneously. So a couple examples of these mechanisms include increased expression of other beta-lactamase enzymes, for example, extended spectrum beta-lactamases or ESBLs, or possibly AMP-C beta-lactamases, usually coupled with a concomitant decrease in outer membrane porin function. Other mechanisms still could be altered penicillin binding proteins that would render the gram-negative resistant to the carbapenem antibiotic. Understanding these resistance mechanisms is really key when designing treatment regimens to treat patients with suspected or documented CRE infections. Being able to anticipate and then confirm the underlying resistance mechanism helps you pick the most optimal therapy to treat your patient. At baseline, it's important to identify patients at higher risk for CRE infections, and this is because our susceptibility testing can take a while to come back. Risk factors for CRE include prior antibiotic use, prior colonization and/or infection with a CRE isolate, and invasive procedures and/or devices, such as mechanical ventilation, hemodialysis, or the presence of other invasive prosthesis in the patient. Resistance can also be acquired while traveling from highly endemic regions with antimicrobial resistance. Recommendations from the Infectious Diseases Society of America, or IDSA guidance, on the treatment of antimicrobial resistant gram-negative infections are generally organized by whether a carbapenemase was able to be identified. If so, recommendations are further guided by the identity of the specific carbapenemase found, such as either a KPC, a metallobeta-lactamase, or an OXA48 enzyme. This is particularly true for infections outside of the urinary tract, such as bacteremia. Recommendations are summarized in the ClinicalThought blog post that corresponds to this podcast. Luckily, there exist both phenotypic and genotypic rapid diagnostic tests, or RDTs, to help identify the presence or absence of a carbapenemase enzyme. The genotypic RDTs in particular have the advantage of identifying specific beta-lactamases that are present, and this includes some of the most common carbapenemases we see in our clinical practice. These could be identified within a gram-negative bacterial isolate in as little as a day from culture obtainment. Many of these RDTs are performed on pure growth from any culture, but even faster turnaround times can be achieved with RDTs designed to be performed directly from blood specimens or other bodily fluids. When a specific carbapenemase is identified, the IDSA guidelines recommend treating the systemic CRE infection with a preferred regimen based on the specific carbapenemase that's found. Not only are genotypic RDTs for carbapenemases necessary for selecting appropriate treatment for CRE infections, but their use of these tools in general has been associated with improved patient outcomes. Based on a recent meta-analysis, use of genotypic RDTs in the management of bloodstream infections in partnership with a local antimicrobial stewardship program has been associated with reduced time to optimal therapy, improved length of stay, and decreased mortality risk. If you do not have genotypic rapid diagnostic tests for carbapenemases at your practice site, it is important to advocate for them. Of note, current genotypic RDTs cannot identify AMP-C beta-lactamases, altered penicillin binding proteins, or porin mutations that many non-carbapenemase producing CRE can possess. The guidelines also recommend preferred treatment options when carbapenemase testing is negative or unable to be performed. Again, I encourage you to look at the ClinicalThought, which summarizes those specific recommendations. So now let's return to our patient with an NDM-producing Klebsiella pneumoniae bloodstream infection and discuss potential treatment options. So based on the available data from this case, coming together with the IDSA guidance recommendations, there are two preferred treatment regimens recommended at this time. The first option would be a combination therapy of ceftazidime, avibactam, plus aztreonam. The second option would be monotherapy with cefiderocol. So let's talk about the first option of ceftazidime, avibactam, plus aztreonam. Although aztreonam remains stable against the NDM, which is being produced by this Klebsiella isolate, the use of aztreonam monotherapy is not recommended because of the possibility that the isolate can carry other beta-lactamases, such as AMP-C or ESBL, that would render the aztreonam inactive. Therefore, we have to do combination therapy with ceftazidime, avibactam, plus aztreonam in order to get a synergistic therapeutic effect against MBL-producing Enterobacterales, such as NDM, including if they have some of these other beta-lactamases present at the same time. And it's really the avibactam as the beta-lactamase inhibitor that's lending protection against some of these other beta-lactamases that can be present. Because of the mechanism of action for these agents, we should administer them simultaneously whenever possible to maximize bacterial killing and optimize pharmacokinetic and pharmacodynamic targets, namely the percent time above the MIC for these beta-lactam and beta-lactamase inhibitors. There are clinical data supporting the use of this combination regimen, and they've been evaluated in a prospective study by Falcone and colleagues And these included a study of NBL-producing Enterobacterales bloodstream infections. In this study, 82 patients had NDM-producing isolates, and 20 patients had isolates with VIM-producing strains. When compared with other active antibiotics, patients who received ceftazidime-avibactam plus aztreonam had significantly lower 30-day mortality rate, 19.2% with ceftaz-avi plus aztreonam, compared to 44% with the comparator arm. They also had significantly decreased 14-day clinical failure and significantly shorter length of hospital stay from the bloodstream infection onset. Now, shifting to the alternate regimen, cefiderocol, it's another treatment option for NDM infections that the IDSA guidance does acknowledge as a potential option for an NDM-producing infection. Data support the use of cefiderocol for NDM infections, and these really stem from two randomized phase 3 trials, the Credible CR trial and the Apex NP trial. However, it's important to note that NDM infections accounted for only a small portion of the patients enrolled in both of these trials. In a pooled analysis of these studies, cefiderocol monotherapy was found to be effective for MBL infections compared with the best available therapy or high-dose meropenem. So there were 24 patients in the cefiderocol monotherapy arm with MBL-producing isolates compared to 10 patients treated with the high-dose meropenem or best available therapy option. Clinical cure rates with cefiderocol were 70.8% in the cefiderocol arm versus 40% in the comparator group. A lower mortality rate was also observed in those receiving cefiderocol at 12.5% compared to 50% mortality in the comparator group. So these are limited data, but they give some support to the option of cefiderocol monotherapy for an NDM-producing isolate that's causing an infection. Another note on an additional class of agents to consider is tetracyclines. Tetracyclines such as tigecycline or ravacycline are listed as alternative antibiotics to consider for MBL-producing Enterobacterales. However, it's important to note that data for these particular infections are incredibly limited, and mostly the data are derived from in vitro studies. In the opinion of the IDSA guidance, these particular agents, tigecycline and ravacycline, should be reserved for intra-abdominal infections and avoided for the treatment of urinary tract infections and bloodstream infections, such as what this patient has, because of their large volume of distribution and rapid tissue distribution. If one is considering tigecycline for CRE infections, higher doses are in fact recommended in order to achieve pharmacokinetic and pharmacodynamic targets. For example, tigecycline 200 milligrams should be given as a loading dose, followed by high dose 100 milligrams every 12 hours. So coming back to our patient case, in my personal opinion, there are no data to compare directly the two main options of either the combination therapy with ceftazidime-avibactam plus aztreonam or cefiderocol monotherapy for the treatment of an NDM-producing CRE infection in this particular case. In my own clinical practice, I have a slight favor for ceftazidime-avibactam plus aztreonam. I personally feel more confident that an antibiotic that includes multiple pathways to evade emergence of resistance, especially in a patient such as this who has a chronic suprapubic catheter, chronic prosthetic material, that is at risk for future infection relapse and or recurrence. So I like the idea of having a regimen in the form of ceftaz-avi plus aztreonam that contains not only a beta-lactam, in fact, 2 beta-lactams, but it really has a beta-lactam and a beta-lactamase inhibitor at least to potentially evade multiple mechanisms of resistance. In comparison to cefiderocol monotherapy, which looks very potent in vitro, but is really a beta-lactam only regimen. So this is a slight preference. There are no data to support one way or the other, but that's just my clinical opinion. Although susceptibility testing for cefiderocol is currently more accessible in clinical microbiology laboratories within the US, I personally am comfortable relying on existing in vitro surveillance data for ceftazidime-avibactam plus aztreonam in order to treat this patient's infection empirically as I await susceptibility testing of this patient's isolate from an outside laboratory. Again, this is just my own expert opinion. Hopefully it gives you some things to think about. And it's my hope that we will have comparative effectiveness data in the future to further elucidate preferences between these regimens. As a last comment regarding tetracyclines, just to be clear, I would avoid tigecycline or ribociclib for this patient case, given their clinical syndromes, documented bloodstream infection, and urinary tract infection. In general, tetracyclines have poor drug exposures in both of these body sites, and local subtherapeutic exposures might decrease the clinical effectiveness of such agents for an infection such as the one this patient has.
Thank you very much to Dr. Justo, and thank you to our listeners for joining in. As a reminder to view the full Creating Success, Optimizing Antibiotic Therapy for Carbapenem-Resistant Enterobacterales Bacteremia program on the CCO and ProCE websites, click on the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.